Hello and good morning. Thank you so much for inviting me in today. I know your time is precious, and I promise to get through this material on the 5As for nicotine cessation as efficiently and as I possibly can. My name is Jim Pavlik, and I'm the Senior Program and Policy Analyst at the Behavioral Health and Wellness Organization at the University of Colorado Anschutz Medical Campus. And I have no conflicts of interest to declare. I'm not here to sell you on any specific drug or treatment modality. My sole interest is to share with you the simple evidence-based gold standard of care for engaging your patients in a tobacco cessation attempt. This gold standard intervention framework is called the 5As. This is a field-tested protocol designed by primary care physicians to be used by primary care physicians to engage patients in a tobacco cessation attempt within the span of a regular clinical encounter. One of the nice things about the 5As, in addition to its over 3 decades of use in such settings for tobacco cessation, is that since its creation has been tested for use in a variety of chronic disease prevention and treatment efforts, including nutrition improvement, physical activity, diabetes management, and high blood pressure management. So once its components are learned, they can be easily applied to a variety of complicated patient management problems that your clinic is already likely working on. The 5As are in order: ask, advise, assess, assist, and arrange. And we'll go through each of them in turn. Ask is a basic screener. Now, one thing we should make clear here is that nicotine itself is not the primary cause of disease. In fact, for non-pregnant or nursing individuals over the age of 25, the risks from nicotine, aside from nicotine dependence itself, are very low. The driver of tobacco-related disease comes from exposure to toxins found in the tobacco leaf itself, the byproducts of combustion, and in the case of newer products like e-cigarettes, from manufacturing components in the body of the device and from the flavorings added to the nicotine solution. However, nicotine is the driver of addiction in these products. So nicotine is the reason that your patients return again and again to these devices, exposing themselves each time to these toxins in such a manner that damage to their bodies accrues over time, eventually resulting in the deaths of somewhere between a third and a half of daily users. Tobacco use remains the #1 cause of preventable disease and death globally in the United States. Which is to say that this screener is asking about nicotine exposure, because nicotine exposure puts the individual at risk for nicotine dependence, which in turn puts them at risk for tobacco-related diseases. Bear in mind that between a third and a half of individuals who use tobacco regularly will die from that behavior, but not everyone who gets a tobacco-related disease will die from a tobacco-related disease. So the number of people who suffer from premature morbidity will be higher than that 1/3 to 1/2 statistic. It is estimated that approximately 16 million Americans currently live with a tobacco-caused chronic illness. Now, if you happen to be working with children or families, then it is also worthwhile at this stage to screen for children's access to nicotine products. From April 2022 to March 2023, over 7,000 calls were made to poison control centers regarding nicotine exposure. Over 80% of those cases were in children under 5. Nearly 600 of those individuals required medical attention, and 43 of them had to be admitted to the hospital for care. Now, there are a lot of ways to screen for nicotine exposure, and the right way is the way that most helps your clinic direct your patients to the help that you can provide to them. We recommend a comprehensive screening question that explicitly mentions cigarettes, vapes, and nicotine pouches. We mention cigarettes because this still represents the majority use among adults, especially adults over the age of 25. But we also want to specifically mention vapes and pouches because consumers of these products often don't think of themselves as smokers or tobacco users, and we want to make sure they understand that there is no safe form of recreational tobacco use. If you choose to screen for other types of exposure, we have provided examples of some of those screening questions as well. Advice. If a person does screen positive to regular exposure to nicotine, then we want to move on to the next 5 of the 5As, advise. The advice to quit should be delivered in a compassionate and non-judgmental way. This is important. Everyone knows that tobacco use is a risky behavior. 90% of smokers say they regret having started, and the leading source of that regret is the knowledge that the thing that they regret which is smoking, is the thing they're most likely to die from. Regret is an emotion that is inherently tied to self-judgment, shame, and guilt. The constancy of critical self-assessment makes this wound one that's easy to aggravate. To be seen judging or lecturing the patient is often counterproductive to the goal of getting them to quit and risks ruining the patient-provider alliance. In addition to being non-judgmental, the advice should ideally be tied to some personal characteristic of the patient that will make the advice resonate with them. The most obvious tactic here is to tie their tobacco use and cessation to the primary cause of their visit. Tobacco use either causes or is associated with all of the US's top 10 causes of death, including heart disease, lung cancer, diabetes, and lung infections like pneumonia and influenza. It is also related to asthma, ear infections, and throat infections in children. So the opportunities for connection here typically are readily available. For all of the 5As, or I should say most of the 5As, we recommend scoping down the delivery of the service to the professional with the most time who also has the skill to perform the task. This one is the exception. In this case, the evidence has shown that the highest level clinician has the most potential impact. Y'all, am I sharing my screen?
No.
Oh my gosh. Oh my gosh. Okay, so there's a great slide deck that I'm not showing you all. Well, that's unfortunate. It's okay. Now you guys can see it. We can see from the clinical practice guidelines treating tobacco use and dependence that administrators have no effect on improving the chances to quit, but the improvement grows from self-help materials to non-physician clinicians up to physicians who can more than double the odds of abstinence at 5 months. Once the advice to quit has been delivered, we move on to the next A, which is assess. This is the beginning of the development of a treatment plan. The level and type of treatment a patient is recommended should be proportional to the level of intensity of their dependence. While not absolutely required, we always recommend using a validated instrument to assess the level of dependence, such as the Fagerstrom test for nicotine dependence, also called the FTND, or the heaviness of smoking index, or the hooked on nicotine checklist for adolescents. On this slide are all 6 questions of the FTND. As you can see, the patient simply answers these 6 questions. The questions each receive the answers that each receive a score, and the scores are tallied. This gives a response set that runs from 0 to 10, which is then divided into tiered assessment or a tiered assessment of their dependence from low to very high. One nice thing about the FTND is that each of these tiers is then matched to a baseline recommendation for nicotine replacement monotherapy or combination therapy. Now, these recommendations do come from 2008, a time when physicians were much more concerned than they are today about the cardiovascular risks of nicotine replacement therapy. So I would suggest using the recommendations from this assessment as the dosing floor and to be very willing to go up from there if the patient reports continuing to struggle with cravings. Another nice thing about the FTND is that if it is too long at 6 questions, you can instead ask only questions 1 and 4. These 2 questions, circled here, comprise the entirety of the heaviness of smoking index, or the HSI, another validated tool. Both of these tools, the FTND and the HSI, have similar validation scores as measured against abstinence at 6 months. If you have been through a 5A's training before, you may be shocked to have heard me say that we move immediately from the advice to quit directly to the early stages of preparing a treatment strategy. In the old days, we used to say that we would assess the patient's stage of change. And if the patient was at least considering quitting, being in the contemplation stage of change, only then would we proceed to the assist stage. Well, the medical societies have, just in the last few years, began adopting and promoting an opt-out approach, aligning tobacco treatment with the treatment of other chronic diseases. So just as a doctor who sees the blood work that suggests a patient has prediabetes simply moves toward treatment planning, when a doctor sees the signs of nicotine dependence, they are now to move directly into treatment planning. Since this is already standard practice in non-tobacco related contexts, I'm not going to labor the point here, but if you would like more resources regarding this shift in treatment methods, let me know and I can send some your way. Assist is the next A of the 5As and the one that seems the most daunting in terms of time. However, this does not have to be a full class on the ins and outs of tobacco cessation. Rather, assist simply consists of a brief bit of counseling, a recommendation for medications, referrals to a treatment provider, and possibly the identification of potential barriers that would prevent the patient from engaging with the treatment plan and possible solutions to those barriers, which is to say, precisely the same things you might do with a patient in regard to a new diabetes diagnosis. The only thing that may stand out as foreign territory is the tobacco counseling piece. Many doctors, when I say counseling, hear therapy. We're not talking about therapy. By counseling, we merely mean brief education around the harms associated with tobacco use, the benefits of quitting, and an introduction to their treatment options. Again, the same things you're used to doing with your patients for other conditions. There are two approaches to treating nicotine dependence, the medical approach and the psychosocial approach. That is through FDA-approved pharmacotherapy and through coaching or counseling. And the evidence-based gold standard is to combine these two for the best possible result. There are 7 FDA-approved pharmacotherapies. 5 of them contain nicotine and are thus called nicotine replacement therapy. And of these 5, 3 of them are sold over the counter. The over-the-counter medications are the patch, the gum, and the lozenge. There are currently no manufacturers of the nicotine inhaler. So while it technically remains an FDA-approved tobacco cessation medication, the only non-OTC NRT is the nasal spray. Because of time, today I won't be going into the proper way of recommending or prescribing these products, but if there is a need, I can consult with you one-on-one after this presentation. I can come back in for a presentation on this topic, or I can send you resources that you can review in your own time. The key note for recommending or prescribing NRT is that the dose of nicotine from the NRT should initially match the estimated nicotine the patient is getting from their tobacco product, no matter how high that estimate is. For the psychological or psychosocial support, we recommend that all medical sites refer their patients to the Colorado Quit Line, where they can receive up to 5 outbound coaching calls and unlimited inbound coaching calls from trained tobacco treatment specialists. And most callers to the Quit Line will also qualify to receive free or subsidized medications as well. Referring your patients to the Colorado Quit Line is easy. It is possible that your clinic is already set up to refer patients directly electronically through your electronic health record system. But if not, you can use the Fax to Quit form, which you can find online through the CDPHE website and print them off. I recommend filling out your clinic's information at the top ahead of time before you print them so you can save yourself some time with each referral. You can also enroll your patients through the web enrollment page. Of course, patients can enroll themselves online or by calling the Quit Line themselves, but there's always the chance that they will fail to remember to do so once they get home after leaving the clinic. Life gets in the way. So the best way to ensure your patients do get enrolled is to refer them yourself. If your clinic would like to learn how to make Quit Line referrals or to just get better at making them, let me know and we can discuss some strategies. There we go. After we've made the treatment plan, we move to the final A, arrange. Here we take the steps necessary to initiate movement on the treatment plan, which is to say that we submit that fax referral, we prescribe the medication, we connect the patient to any outside or transitional care providers using warm handoffs if possible. And crucially, we arrange for a follow-up visit to discuss progress on their tobacco treatment plan. This could be a phone call, a televisit, or in person, whatever is best and allowed at your facility and fits your time constraints and other needs. But we know that people are better able to commit to their quit plan when they know that in pretty short order, they will be called to account for their progress or lack thereof. We do imagine this as a cycle where the patient gets re-screened, et cetera, at every visit. We also recognize that this may be unworkable for your clinic. If you can hit this high bar, this is where we see the greatest results. If not, we understand that too. Most accrediting bodies that track tobacco services require all adults to be screened and provided resources at least once every 2 years. Now, like I said, the 5 A's that we've just gone over was designed by PCPs for PCPs to be delivered approximately in 10 minutes or so or less. But we understand that even that may be too lengthy. As a result, researchers and PCPs also created the two ways in an R: ask, advise, and refer. Now, ask, and advise are the same as before: the simple screener and the advice to quit delivered in a non-judgmental manner. But then it skips right to refer, not to arrange as previously, but refer. And the most common referral site will continue to be the Colorado Quit Line. But I always do add a few caveats to this. One is that whatever treatment provider we refer to should still be matched at least a little bit to the intensity of the dependence, which is hard to do without an assessment. One solution here is to move the assessment to the intake process, like a second sheet of paper given to the patient during the intake documentation that they fill out if they say they are a tobacco user. Another way is to simply ask the patient if they feel dependent, and if so, how much so, like maybe on a scale of 0 to 10, for example. Another thing to keep in mind is that if the patient doesn't like or want the type of service that you refer them to, then they're not going to engage with it. So it won't matter how much time you save by adopting the 2 ways instead of the 5 A's, because every minute that you spend making that particular referral is still going to be wasted. So we do have to ask the patient what kind of support they're hoping for. If they initially balk at the quit line, but express interest in medication, and you are unable to engage with them on this medication issue, then remind them that the quit line has tobacco cessation specialists who can guide them to the best options for them and are also likely to be able to provide those medications potentially for free. Now, at this point, we have covered the 5 A's extremely rapidly. It took me just over 15 minutes or so to explain the key concepts, which is an interesting and not entirely coincidental length of time that roughly corresponds to the maximum amount of time that we think a clinical team should be able to get through the entire protocol. But we also know, and not to get too cynical, that time is money. And we want you to know that you can bill for this intervention. The qualifications for tobacco cessation counseling are what I already mentioned: patient education on the harms of use and the benefits of quitting, a review of cessation options, which includes both behavioral support and medications, and ideally referrals and/or prescriptions to those services. As you know, billing can be quite complicated, as which codes are appropriate depends on the provider type, the treatment location, certain patient characteristics, and sometimes, as in this case, on how long you perform the counseling. For most treatment settings, the 2 codes you're most likely to use are 99406 and 99407. Both of these are codes for the provision of tobacco cessation counseling. 99406 is the code for counseling that lasts 3 to 10 minutes, and 99407 is the code for counseling that lasts longer than 10 minutes. There are other ones, and I have a collection of billing guidance documents that I can provide to you. And that is the entire 5 A's. Thank you all so much for your time. If you want to reach out and schedule another presentation, this is my contact information. So y'all, that's it. That's the whole 5 A's. For the most part, I have a bunch of caveats. You can see that I have an entire section coming up called Notes for Trainers. But I'm going to pause, as I said in my email, and see if there are questions or comments. And apologies for not showing the first 3 slides. I can assure you they are mostly just lists, and you didn't miss any fancy graphics. Are we just anxious to get to the notes? Okay, well, hearing none, I will head into the notes. I'm gonna turn my camera back off for those as well, just so I don't distract myself waving my hands around like I do. So one question right off the back that I would have for myself is, why did I do a 5 A's training for primary care clinics? Why didn't I choose some other kind of community partner? And the primary care clinics are among the most difficult spaces to deliver 5 A's training in from a logistical point of view for 2 reasons. As easily the biggest difficulty is time. Especially for small clinics thinking 5 or fewer providers, they're packed from open to close. And many PCPs in those clinics often report not taking lunch breaks. Instead, they snack when they can in quick breaks between patients, oftentimes while typing notes for a previous patient or reviewing notes for an upcoming one. Even if 1 or 2 of the physicians do take lunch breaks, it's rare for all of them to do so, and rarer still for all of them to be able to do so at the same time. Similarly, the administrative staff are constantly working. In many small clinics, the front desk and all of its associated duties are managed by one person at a time, sometimes one person totally. There is no backup, and the desk simply can't be abandoned for any length of time, not for 30 minutes and certainly not for an hour. The other difficulty is that primary care clinics, although they sound like one specific thing, are actually pretty heterogeneous. Primary care clinics are, primary care providers are general practitioners, family practitioners, OBGYNs, pediatricians. The staff often include those MDs, also DOs. Some smaller clinics may not have an ND or DO, but instead have all or most of the care delivered by a physician's assistant or a nurse practitioner. Some clinics have a doctor part-time and a nurse or a PA whenever the doctor is out of the office. Larger clinics will have doctors, nurses, physician's assistants, medical assistants. Other kinds of clinics may have psychiatrists and pharmacists. So to present at a quote unquote primary care clinic actually may mean presenting to 5 or 6 or even more different types of professionals. So it presents 2 different kinds of challenges, right? So then the question is, how do you present to an incredibly busy clinic? And you kind of do what I just did here is the answer. The answer is you have to be extremely brief and relatively high level while providing at least a few areas for genuine engagement, which is what I tried to do. You could definitely do a better presentation. As a matter of fact, I've never given this skeleton version of the 5 A's. You can, for reasons I'll get into, you can deliver a more engaging one, a more practically minded one if you had more time or knew for certain that your audience was going to be more homogenous. And that both of those cases tend to be true. So another question I would have for myself is, why did I do why did I train the full 5 A's knowing full well that these places are busy and are most likely to adopt the 2 A's and an R? And I would go a little bit further and say, why did I do both? Why did I train the 5 A's and the 2 A's and an R? I would not recommend that strategy at all, just for time reasons. You should just pick one and stick to it, is do it really well. I would work with whoever arranges for you to come in to see if they would prefer the 5 A's or the 2 A's and an R, and only concentrate on that. I did the full 5 A's here because I hope that I made clear that in order to do the 2 A's and an R properly, you still need to know, they still need to do a little assessment and a little assistance, and they should still be kind of arranging for follow-up care too, which is to say that the 2 A's and an R is really, when it's done well, just a very fast 5 A's. So you as trainers need to know how to do the full 5 A's or how to train the full 5 A's in order to train the 2 A's and an R properly. I included the 2 A's and an R in this presentation simply because that is the training you are most likely to give. And I wanted you to have access to the high level talking points that I would go into were I to give that training. So in at least one way, this is good news because I got through that entire thing in about 15 to 18 minutes, which means that should you elect to do just one or the other, you should be able to get through it even faster with practice. So what are some general tips for adapting this training? It's always useful to use illustrative examples and cases. Most healthcare professionals in particular are familiar with the idea of case studies. So use a case study of a type of patient or client that type of provider would actually see. Also, since I just mentioned it, try to use patient or client or consumer or customer, whatever term the audience typically uses to refer to the people they serve. Medical providers tend to use patient, which is why I used it today. Behavioral healthcare providers most often use client. Sometimes you'll hear consumer. Some refer to residents. Some use enrollee. Sometimes you'll run across member. If you don't know which term they use and you can't ask ahead of time, normally you can actually ask on the day of the presentation, but you can also just default to client. Most everybody understands what you mean when you say client. That's been my experience. But they're going to be more comfortable if you use the term they use. If you do have more time than the 15 minutes that I allotted myself, or I guess I allotted myself 20 minutes, but if you have more time than that, there are 5 good options for additional material to add. So, and they're listed here. So time is ultimately going to be your most important consideration. If they give you an hour, use 40 to 45 minutes only for content and reserve 15 to 20 minutes for questions. I think in 40 to 45 minutes, you could handle the entire thing I just gave, plus probably billing and quitline referrals. No one ever hates getting out of a presentation early if they run out of questions. And I think that 40 minutes is probably suitable, if not a little long, for covering all of the 5 A's plus billing and quit lines. You could also add another topic, and I'll talk about that just from the board here. It's very hard to go shorter than what I did today on this topic. If you have to do the 5 A's, it's really hard to do it in under 15 minutes, 20 minutes. But I have given trainings on screening and referral to treatment. Like those are the two topics, screening and referral to treatment, skipping right over even the advice to quit, which is to say that I've given trainings on how to make quit line referrals. Another way to say this is that although the 5 A's remains at the core of systems change work, we always cater the conversation to the unique needs, demands, constraints, requests, etc. of the place we present. On a scale of 0 to 10, implementing the full 5 A's from scratch at a willing site, it's maybe a 6 in terms of difficulty. This isn't particularly hard work. There is legitimate work that has to be done, decisions that have to be made, buy-in that has to be cultivated, forms that have to be created, but the difficulty drops precipitously if they're already doing any element of the 5 A's, which they almost certainly are. If good screening questions are already included in the vital section of their EHR, that is a huge step forward to getting to the full 5 A's. If they're already making quit line referrals, even if irregularly, that's even bigger. So if they just want to hear about one aspect of the 5 A's, then that's what I'm going to talk about. There's no magic in the 5 A's as an acronym. It's not a spell, right? It's not from a grimoire. There's no need to call it the 5 A's if that's off-putting. As a result, when I did screening and referral to treatment, I didn't call it 2 of the 5 A's. I called it in one instance, screening and referral to treatment for tobacco cessation, and in another instance, making referrals to state tobacco quit lines. So in order, like the things that I would add once you're given more time is, first of all, a good primer on how to make quit line referrals. And obviously in Colorado, you'd make that specific to the Colorado quit line. The next thing I might add, especially in a primary care clinic, is information about how to recommend or prescribe FDA-approved pharmacotherapy. That's a great addition. The sort of conversation that leads tobacco users to the best medication for them are the kinds of conversations that medical providers are really accustomed to having already. So these conversations fall within the assess and assist domains of the 5 A's, and getting them excited about the potential successes of NRT is a good way to engage them in these components of the 5 A's. And then the third best one here, I think, is a conversation around billing. And I know that billing is going to be confusing or scary for some of you. It's scary and confusing for anybody who doesn't do it 4 to 8 hours a day. I will be going through some talking points around billing in just a second. Another thing that you can add, if they're not interested in these things, or you have even more time, or you have a tight script and you think you can get through more material, is to concentrate on whatever the newest tobacco thing in the headlines is. Like if I were giving this presentation today, I'd probably have a little breakout moment on the oral nicotine pouches. They're hearing about them and they don't know how to treat them in their offices, so it's great fodder for interest. And then the other thing I would include, and you might just make this boilerplate, honestly, is just a brief tour of your local tobacco program. What is your website? What resources are on it? What kinds of trainings can you provide, et cetera, those kinds of things. Knowing you and the relationship you build with them is like sort of the most important thing that you're doing it there anyway. They're not likely to change their workflows overnight, but they are learning about you and your level of expertise. And that's the most important thing. So here's my notes. Here's my notes on billing. You are going to get questions about billing. So you should know just the things on this slide, right? So what the question is, what do you need to know about billing? And my first response is not as much as you probably think. Billing is the most esoteric component for those hoping to facilitate systems change, because to do it well, it does require domain-specific expertise, as well as firsthand operational expertise to truly understand the barriers to getting reimbursed. The good news is, as I've implied here, is that as a facilitator for systems change, you're just never expected to be an expert in billing. Rely on the experts in the room to close the gap between the tobacco things that you can say, which I'm going to go over, and the operation or the implementation of those things, which is what they already know how to do. So what is billing and what are billing codes? I sort of start from the ground up. As simply as possible, providers perform services. And these services use up resources, both material, financial, and temporal time. As a result, providers need to get paid to do those things, or they simply will not do them. The process of billing involves identifying who should pay, right, who the payer is for the service, and then telling that payer what was done in a standardized way so that the payer can pay the appropriate price. So while in theory, the array of services that can be provided by a provider are endless, and they may appear in a clinical encounter in an infinite number of combinations, the reality is that most providers perform many services repeatedly, the most common being largely dependent on the field they practice in. Routine services have been identified, assigned a code, and a standard reimbursement rate, right? So this is it. That's the whole thing. Each service has a billing code, and each billing code has a reimbursement rate. Although private party payers, which is that's our large and small corporate insurers and our individual marketplace insurers, they can all set their own rates, but most reimbursement rates tend to gravitate toward the rates published by the Centers for Medicare and Medicaid Services, also called CMS. State Medicaid offices separately publish their reimbursement rates, since not every Medicaid office turns on or accepts every CMS code, and because states can separately prioritize which services they want to see more of by raising the reimbursement rates for those services. So the two codes, and I said this in the presentation, the two codes you're going to see the most often are 99406 and 99407. You might as well just memorize those. These are time-based codes, as I mentioned in the presentation. The codes are for tobacco counseling. And to qualify as counseling, it's exactly what I just said in the presentation, no more, no less. The provider should include three components in the billable intervention, which includes education on the harms of use and education on the benefits of quitting, and then information regarding evidence-based cessation interventions. And just for the record, I didn't say it in the presentation, but you should know that all the evidence, quote unquote, evidence-based cessation interventions are those that are given a grade of A or B from the United States Preventative Services Task Force. And right now, all tobacco cessation interventions have an A attached to them. Some payers may require that counseling involves specific instructions around FDA-approved pharmacotherapy, including an official recommendation for an official recommendation or prescription for medication to qualify. Because, I'm sorry, and I'll pause here. The reason all this is important, and we'll talk about some common reasons why reimbursement fails, and I didn't say it in my notes, so I'm going to say it right now. All of this stuff has to be documented, right? They have to get this material into the notes that they send to the insurance provider so that they can see that these components existed in order to qualify for billing 99406 and 99407. And there's also the case that some accrediting bodies, like the Joint Commission, they also require an official recommendation or prescription for FDA-approved pharmacotherapy. So this presents them, the clinics, a really good opportunity to align their billing and their accreditation processes that they're going to be going through anyway. There are other codes that can be used for tobacco interventions. Some of these vary by the precise services being offered. Some clinics, for example, may have found success billing a tobacco screening as part of a larger wellness assessment under the code 99385. You don't have to memorize that. That 99385 code is called labeled preventive visit established patient 18 to 39. That's the kind of boring, complicated stuff that you don't need to know, but you need to know exists. Group classes, as another group intervention or group counseling classes, use a different code than individual counseling. Basically, the list for tobacco cessation interventions is actually quite large. But the primary reason for the use of different codes is that different providers have access to different codes. So in order to explain all this a little bit better and a little bit more depth, I am providing you a list with links to various guidance documents, billing guidance documents. So you'll have access to reading those, and they make it quite simple. One of the questions that you will get, especially if you include billing in your presentation, but even if you probably don't, people are gonna ask, we've tried to bill 99406, we've tried to bill 99407, and the insurers kick it back without paying for it. So why? And they're going to ask you why. And here are the most common reasons, and you don't need to come up with their answers because you can't. The only person who can truly answer that question for them is the insurance payer. But here are the most common, which I think I have on the board here. There's oftentimes a mismatch between the providers and the codes. The first thing they should do is check if their profession, their providers, their clinic should be using different or more specific codes. Different providers have access to different codes. I've said it 3 times, but it's something worth knowing. And insurance companies can be over fastidious on administrative particulars in order to escape their financial obligations to the clinic and to the patient, right? Insurance payers don't want to pay money if they don't have to. I've provided several billing guides below. But if the profession that you're about to present to isn't included in the list of links that I'm providing for you, then I've typed in my notes here that I'll also be giving you the search phrase that I use to try to find if there's any billing guidance for that profession. And essentially that is, I say tobacco billing guide. It's really simple. And then I type in the profession, so pharmacist maybe, and then I type the phrase file type : PDF. And that's going to return only PDFs, which tend to be nice, stable documents that you can print out and hand out as a resource to your audience. Another common error here is that they don't use a diagnostic code, which is to say that there's the billing codes that we've been talking about, 99406 and 99407. That's the services billing code. But why are they performing that service? In order to qualify for reimbursement, the service can't just be performed; it has to be performed for a reason. And the reason is because the patient visited them. I'm sorry. How do I say this? All billable service should be performed for a reason. And typically a service is performed because the patient is suspected of having, or is at risk for a diagnosis. So whenever applicable and whenever possible, whatever billing code they're using should be attached to the appropriate diagnostic code. So we're talking about like a DSM-5 code for tobacco use disorder, right? TUD, or we're talking about an ICD code for congestive heart failure or for diabetes, right? Something that's a tobacco-related disease. The third one, and this is the one that is the most wonky and the most confusing, and the one that I think people are the most afraid to say out loud to experts because they're not an expert in it, but they didn't use the right E&M modifier. The right E&M modifier. Most providers, you don't need to know a lot about this if you're already like, oh God, rolling your eyes and breathing aside to get ready for this torture. But most providers are not engaging with the patient on tobacco cessation because the patient visited them primarily or explicitly for that purpose, right? The patient came in for some other reason other than tobacco cessation, and the doctor is now doing tobacco cessation. So now there's two things happening in encounter, and you really only have to bill for one thing. And so most providers will be addressing tobacco cessation as part of a larger treatment plan for some other primary diagnosis or procedure, right? And because of that, just because of the way the rules are written, they have to use this thing called an E&M modifier. E&M stands for evaluation and management, I think. And the modifier we use in the tobacco world for tobacco cessation services is 25. Now, the thing is, that's all you need to say. If somebody's asking you what the E&M modifier is, or if you say like, oh, you have to use the E&M modifier and the modifier you should use is 25, if they know anything about billing, like if they're involved in billing, if they're the expert for their office, they're going to know exactly what that means. And that's all you need to say or know. All right. So in my notes, so I said in the email, but just to clarify, what I'm providing after this, what I'll be uploading to Tobacco Free CO, is this slide deck. The first half of this slide deck, the part that is the 5A's presentation, I'll be providing that to you as a PowerPoint so that you can change those slides, add those slides, delete those slides, edit those slides. I don't know if there's typos in there. I hope not, but it's yours. You can just, it's for grantees. You can do whatever you want to with it. Obviously, if you use our slides, we'd like you to leave our branding on it, or at least cite us when necessary, but otherwise it's your slide deck to do whatever you please with. I will also be giving you a PDF of this entire slide deck, which includes both the 5A's component and these notes. I am also providing you with the script that I was reading for the first part of the presentation. And I will be providing you the script that I was reading off of for these notes. And I'll be providing a list of other materials. So I think that literally, if you went into an office of any site or any type with this script, more or less memorized and kind of flavored for your own diction and language and flow and whatnot, you're going to be great. That's going to be all that you need to say or do. You might not feel confident that that's true. And there are certainly ways that you can expand your knowledge base so you can be more fluid when you're answering questions. It's better to know more than less with some parameters. The things that I'm also linking to that I think if you think you need to know more, these are the things I would go to. Read about the 5As in clinical practice guidelines treating tobacco use and dependence. Most of you already have that. I probably sent it to you. But if you don't have it and you don't know what I'm talking about, reach out. I will get you a copy. It's a free PDF. You can just search it online and find it. Again, use that file type :PDF language and you'll go right to it. It's a full explanation of not just the 5As, but also all the research about the 5As up to 2007 or so. So it's a super handy, knowledgeable guide that helps you point directly to the evidence base, make you real fluid talking about the sort of nuances within each of the 5As. Typically, you don't need to know them, but maybe you want. Maybe you're like me and you want to know them anyway. If you don't know a lot about the pharmacotherapy stuff, I'm linking to 2 webinars that we created here at BHWP. They're both an hour long. The first one is just the basics. It takes about an hour and it gives you a ton of information, literally more information than doctors graduate from medical school with. That's not to say that it's hyper technical or anything. It's just, it's actually all pretty straightforward, but doctors don't know it. The other one I'm recommending is one that's really on sort of best practices for use and how to talk to patients about those best practices so they're more likely to use the nicotine replacement therapy correctly and therefore, be more likely to sort of stick to the plan. That one is also an hour, but it also reviews the basics. So if you're a person who's already gone through a training or you really feel comfortable talking about pharmacotherapy, just skip to that one. It's, in my opinion, a better webinar overall. If today was the first day you've ever heard of the opt-out approach, I'm linking back to a webinar that my colleague Derek did last year. It's a full exploration of where this idea came from, why we support it, why we think this is a part of an equity focus or a justice focus in tobacco cessation. And then finally, I hope that everybody is really comfortable talking about the quit line. But if you're not, then that's something you should definitely be expanding your knowledge of, because that is the thing that you're most likely to spend the most time on. I didn't go into it today, not just for time reasons, but also because I think that you all really know how to talk about that stuff. But if I'm wrong, please reach out to me and we'll get you caught up to speed. And that leaves us that is the end of my notes. Is how you end that sentence. And that leaves us 18 minutes for questions that I haven't already answered for you. Having a lot of Zoom issues today. So I know that some of you are all thinking about a 5As based training, or a 5As program, an effort, initiative. Did you get what you needed from this? Or do you need to know more?
Do you have any tips for even how to get in the door at a provider's office? Because we struggle with that.
For sure. So it really is, this is one of those things where, we think about like personalities, and this being a real personality driven effort, a real relationship driven effort. They're busy and they are constantly bombarded with people who want their attention, even for any length of time. Obviously, primary care clinics are the greatest example of that, but it's true for almost any place. I'd say primary care clinics are the hardest one to do this in, but you really need to start developing that relationship and you can do that however you can, but showing up in the office and bring them cookies. I'm only being slightly facetious. That has worked for us in the past trying to get into the hospital. You have to remind them that you exist. And if you're kind of always there, you're always somewhere near the top of their mind, when they have time, they will eventually call you in. They have certain requirements, either accreditation requirements or training requirements that they have to go through. And sometimes they have to pay for those. And so if you're offering to come in for free to do these things, they just have to remember that you exist when that time rolls around. That's the hard work, that's the legwork, but that's the truth of the matter. You can also do like some more intense efforts. I mean, you can find people on LinkedIn, start following them on social media. If they have Twitter accounts, try to show up in places where they're at. They're going to be at other trainings. They're going to be at local fairs. They're members of chambers of commerce, or they're board members on like the golf committee, like they're there. So if you're there too, then you have an opportunity to start like meeting them outside of the asking for something space, and then sort of weasel your way in that way. With other types of clinics, it's not quite as hard. Bigger clinics, hospitals, community behavioral health organizations, they all tend to have internal training programs. They have a training director. They have a clinical quality improvement director. They have an HR or compliance director. They have somebody who's in charge of the reaccreditation like program, which is typically run by a board or a task force. And those folks are like the ones. Because if you kind of find them and get to know them, they can just get you on a schedule. Like, oh, we'll just get you in here every June. I worked at a community behavioral health organization in Tucson, and that's precisely the relationship they had with their local county public health. So they did twice a year new employee orientations, and twice a year the Arizona Ash Line was in there giving their hour-long presentation on how to engage their clients with the quit line. So those folks, because they can make it a requirement, and they can just put you on the schedule, like that's typically the way to go. And that's where I would focus my initial efforts. Getting into small clinics is very hard. You tend to have to do it like super early in the morning, like at 5:30 or 6, like before they open the office. It's the only time to get everybody at once. And even then, like they have other meetings. They have to talk about their day. They have to do all the sort of like operational stuff, and they're just cramming you in for the shortest possible presentation. Like lunch and learns is like ideal. Like if you can get a lunch and learn, like that's a gigantic win, but it's mostly like 5 a.m. But yeah, it's really about relationships. And I'm not kidding about like bring them gifts. This is, we talked a couple months ago about like effective uses of quit kits. That's the effective use of the quit kits, is to develop their relationship with the clinic by delivering those quit kits, talking them through those quit kits, making them feel good about giving out your quit kits, and then saying, hey, I'm not asking for much. I just want to come in and talk to the staff about the 5 A's. Great question. I hope that was a somewhat satisfying answer. Other questions? You're welcome. Another avenue is to not go to the clinics at all. It's most states and several regions all have these like provider trainings, like conferences, like CBHC, the Colorado Behavioral Healthcare Council. They hold a big training out in Breckenridge, or a conference in Breckenridge, and you can try to get on that schedule. The various what do they call them here? Are we raised? Yeah, I work in so many states. You have these regional organizations that Medicaid is broken down into with different providers, and those regions also hold large scale trainings. I presented to one, and I literally did the 5 A's in like 10 minutes to 300 providers. It's not desirable. It was really hard, and they obviously didn't care very much. But that's another avenue, is that you don't hit the clinics, you hit the providers in places they're required to be anyway. but you have to kind of do the legwork to find out where those things are. And again, that's another place where like getting to know folks is, and you can just ask them like, hey, do you guys ever like, how do you do your trainings? Where do you go? When do you do it? And then find those providers. So again, referring back to my experience at CVHO in Tucson, they had a regional mandated trainer, and then we had internal training requirements, and so we were always getting like a little catalog of things, and so we meshed our schedule like when could we go out to the training center and get 1 or 2 CEs for the year, and if that's on the list when they're signing up for stuff, then you get to go do the training. Everybody's just anxious to get the materials and leave me out of it. All right. Well, if there are no questions, then
I have a question.
Oh yeah, sure.
Is the reimbursement rate sufficient to pay for an employee who's doing those interventions?
If it's is it high enough that just doing tobacco would then like justify the FTE? Is that what you mean?
No, not one FTE, but to justify the amount of time they spend.
It gets pretty close if they are, especially if they're using it not as a standalone code, but as this with the E&M modifier. So they're already able to build count for 2 things. Then yeah, and especially if the clinic is good at scoping down. So you can do what's called incident to billing, which I guess I didn't get into, but maybe I should. But essentially, you can bill against the primary care provider's code, the MD's like number, but some other provider can actually provide the service. And they just changed the rules on this so that it used to be that the MD had to be present in the room and literally supervise that, say, counseling, but now they don't have to be. And so now the MD can go off to the next patient and start billing for them, and the nurse or a peer specialist or a nurse navigator can handle that counseling piece and then bill appropriately. And once you scope down, once you sort of get the 2-for-1 with using the E&M modifier, and you get to scope down the actual provision of the care to a lower paid employee, to be cynical about it, then yeah, I think it is justifiable at that point.
For those billing codes, is there a specific job title they have to have, or you have to have some nursing training, or can the medical assistant do it?
So these are all great questions. For the incident to billing, I don't think there are qualifications, but I have to double check that. I think anybody can do it because the MD is going to sign off on it. So clearly, the MD, especially in these small clinics, is sort of like the captain of the ship, and they need to make sure that their staff are trained up in order to do those things appropriately, so they can sign off on the provision of that care. It's always built against the doctor, so I think anybody can do it. In terms of if you're not using incident to billing, then your base there is whatever your state Medicaid lists as a qualified provider. So here in Colorado, it's most medical and mental health providers except psychologists and tobacco treatment specialists aren't recognized. If you're in Massachusetts and a couple other states, then tobacco treatment specialists can also bill for those services directly without using incident to in those states. So you start with the CMS list or your state Medicaid office list on who's considered a qualified provider and work up from there, because the third-party insurance providers can recognize whichever providers they want and also exclude any providers they want. And that's the clinics will know who typically can do that and who can't. They'll find out once they try to bill for it. But it's hard for us the insurance companies, like by design, don't share that information out. They're trying to create administrative obstacles. No offense if anybody here works for the insurance industry. Any other questions before we part ways?
Is there any education for staff about using, say, the nicotine gum appropriately as opposed to chewing it like it's gum, or taking off the patch at night if they're having insomnia? A lot of different things like that come up.
Yeah, so like I said, if you get more time, that's an area of hot, like a lot of interest, especially from the providers themselves, because they one of the big blockades of why we ask them, like, why don't you engage in a tobacco cessation conversation, is like they say, I don't know what to talk about. But once they can talk about medicine, then they know how to do that. And so if you can include that pharmacotherapy component, then absolutely, the doctors and the nurses both like to talk about it. And yes, that's exactly the material to cover. You just do what I did here. There's 7 FDA-approved pharmacotherapies. 5 of them contain nicotine. 3 of those are over the counter. The other 2 are bupropion and varenicline. Boom, 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 boom. You're all done with that. You don't need to take a lot of time with it. Then the rest of that conversation is how do we dose it? How do they use it? Those are the 2 topics for sure. And that is essentially, like when I said, like the 2 webinars that I'll be linking to for you guys, that is the topic that we cover in the second one. So it really does cover the basics. But if you need more on the basics, I would start with that first one I linked to and then move on to the how to use it appropriately presentation. But they do cover a lot of the same material.
And if we say that the quit line isn't for them, would educate, if a client were to say that the quit line isn't for them, would we want to educate one person in the staff, a champion or something along those lines, about talking through the triggers, how long urges last, setting the quit date, things like that?
So, yeah. It's a great question. If there is a tobacco champion in the clinic, that person is going to be absolutely critical to you engaging that clinic at any level. It is my preference that the people in that clinic, somebody, doesn't have to, I don't care who it is. It could be, as far as I'm concerned, it can be an MA, it could be a nurse, it could be a PA, it could be the doctor in charge. Any one of those people should take on the burden of counseling, or at least should know how to do it. Because there are going to be some clients who, if they have somebody to talk to, will talk to them. And so somebody in that clinic should be able to take on that responsibility. I want, more than anything, for local places to become service providers and cessation service providers. It's just not a reality. It's not something they typically want to run up into and embrace. And in those cases, it's just the quit line. So, I mean, I think that really speaking enthusiastically about the quit line is a great role for you all when you do these trainings. I mean, either one. I mean, go either way. But if you find a champion, definitely go that way, because it's very easy to do a quit line referral. But if they're not going to, and they don't need to, if they're getting local services. But it is the case that even if all the person wants is medication, that's a cheap or free way to get it, right? So they're saying the quit line is not for them, but they're also maybe remembering a time when the quit line required coaching to get meds, and it doesn't anymore. They might be remembering a time when the quit line didn't have certified tobacco treatment specialists on staff, which they do now. They might be remembering a time when there wasn't a protocol for African Americans, or for American Indians, or for low SES, or for behavioral health populations, and all those things exist now. They might not be remembering a time when there weren't incentives for menthol smokers or for pregnant women, right? Like, that's a different quit line now, and it's a lot of doctors are old people who remember when quit lines didn't work. I mean, it used to be the case that without meds, quit lines had a success rate of 10 to 12, which put them below over-the-counter nicotine replacement therapy. So why would you ever waste the time with the quit line? And I get that, but now quit lines have success rates in the low 40s, the high 30s and low 40s. Like, it's just a different place. So I would be really advocating for getting the quit line into everybody's hands, regardless of whether or not the patient enrolls, and then also then develop local counseling support. We have 30 seconds.
Would we be problem solving with them how to institute this into their flow, or is that something they should do internally?
That's up to you and them. If they don't know from where to go from the end of this presentation, then yeah, absolutely. And then that's up to your comfort level. And if that is beyond your comfort level, not just you, Heather, but anybody who's listening, that's a great time to come back to us, to BHWP, to your TA providers, and we'll be happy to like walk you like you can have a meeting with them and hear what their barriers are. We can brainstorm what those solutions would look like, and if it's complicated enough, like we're happy to join, and if we have time, we're happy to join those calls with you and in those meetings and just brainstorm with them directly. That's a thing that we can do. So I mean, we at least that's a thing we can offer now, because so few people take us up on that. I mean, if all of you were engaging with 2 or 3 or 4 clinics, we might have to put some restrictions on it, but for now I have the time to just do that. All right, we're at time. Thank you all for your attention. I hope I didn't confuse any of the latecomers when I kept referring to your patients and your clinic, but I was pretending that you were primary care physicians or staff members, so that was the point. You'll get all of these recordings and resources probably by tomorrow, is what I would guess. Thanks for attending.